Welcome, everybody. My name is Andrew Olson, and I'm an associate professor of medicine and pediatrics at the University of Minnesota Medical School, where I practice hospital medicine and pediatrics. And today, I get to spend some time with you as the senior director and actually the founding senior director of the Aquifer Diagnostic Excellence course. We're going to spend the next half hour hopefully giving you a chance to think about how you might use this as we talk about a topic that's of increasing importance in medical education and medical practice, and is certainly not restricted to one specialty or even one profession. So we'll spend the next half an hour or so together and leave some plenty of time at the end for questions. I do want to highlight that this project is a partnership between Aquifer and the Society to Improve Diagnosis in Medicine, and we're really delighted to share with you about it today. So this is who I am. I serve as my major job is being a baseball fan, but I moonlight as a person who studies diagnosis and diagnostic error. And this is my 4-year-old. I'm teaching her to be tough. We went to the baseball game. It was 38 degrees, and she got a hot dog, so she was happy. But I've been delighted to devote my career to working on diagnosis and diagnostic excellence, and really trying to figure out ways that we can seek to improve the diagnostic process. I do have a disclaimer that I receive honoraria for my work here at Aquifer, and I'll tell you more about Aquifer as well. I also have the delight that the field of diagnosis and diagnostic error is really evolving, and there's actually money to fund grants. And so I'm excited that I've received and continue to receive funding from the Macy Foundation, the Alliance for Academic Internal Medicine, and CRICO for my work on diagnostic excellence and clinical reasoning and diagnosis. So this is what we're going to do today. We're going to spend a little bit of time talking about this course and what we've designed. It's not so new anymore, but I think I'll continue to reintroduce it to all of you, and then talk about one way that we used it at our medical school, and then spend some time hopefully opening it up for questions and answers. Throughout, please feel free to use the chat to interact with one another. It is easiest if you want me to answer a question for you to go ahead and put that in the Q&A. And we'll be moderating that throughout. I will also make sure that you can certainly contact me or any member of the Aquifer staff as well afterwards to answer any questions that you may have going forward. So what do we do here at Aquifer? So Aquifer is this incredible consortium of medical educators and health professions educators dedicated to delivering the best healthcare education through collaborative development and research and innovative high-impact teaching and learning methods, and started as developing specialty-specific cases, but now have really gone well beyond that. And hopefully most of you are familiar with some of the offerings that we have. Diagnostic Excellence is one of our newer ones that we continue to be quite proud of in our work here. So why is this important? Why did we feel like we needed to develop a course on diagnosis, diagnostic error, and actually diagnostic excellence? It turns out that the field of patient safety there's really got its footing in the early 1990s and then into the mid 90s with studies like the Harvard Medical Practice Study and others, really highlighted that we have a lot of problems with safety in healthcare. And in the last 20 years, the problems that we identified then, medication errors, wrong site surgery, things like that, continue to be focused on, and we've made some progress there. But what's really come to fore in recent years is the problem of diagnostic errors. Diagnostic errors are probably the most harmful patient safety events that happen, and certainly are quite common. Probably 40 to 80,000 people a year die because of diagnostic errors in the US alone. And you might say, well, this is a problem that's due to missing rare things, or it's due to missing uncommon diagnoses, and that's probably not true. The most common diagnoses that missed in the hospital are things like sepsis, stroke, myocardial infarction, and far away the thing that's missed most likely in the outpatient setting is cancer. And so how common is this problem? It turns out that 5% of outpatient encounters have a diagnostic error with recent estimates, and 15% of inpatient diagnoses are probably wrong. The challenge, of course, is we don't know which 15%. But in addition, it's not just about not being wrong. It's about learning from our mistakes, constantly striving to get better, and moving from error avoidance to actually excellence. And I think as I reflect on my own path as a medical practitioner, but also as a learner, watching and seeing that really diagnosis is the foundation of what we do in healthcare. We make management decisions, we make treatment decisions, we make prognostic decisions, all based on what we label a patient as having. And I think that's a really important thing, that if we don't get the basics right, none of these things, precision medicine, none of these things that we identify will work. So we had an opportunity a number of years ago to develop this course that really seeks to introduce learners to really a few things. But first, that diagnostic errors are a problem, that we can learn from them and talk about them in a way that doesn't shame one another, and that we can strive always constantly to improve. We also wanted to talk about the real harms that these have, not only for patients and their families that are absolutely devastating, but also those harms that actually happen for us. I know that I've gotten a little more experienced in medicine. There's not a lot that keeps me up at night anymore. But when I have made a diagnostic error, those are the things that stay with me. And I want to give our learners the wherewithal to and the skills to learn from, reflect on, and improve their diagnostic practice. So I'm going to talk now about what the Diagnostic Excellence course looks like. And no, we call it Diagnostic Excellence, not the avoiding diagnostic error. We really think that diagnostic excellence is a pursuit that is infinitely improvable. We can teach our learners to constantly strive to be better diagnosticians. And that's not only more accurate, but that's more efficient, more patient-centered, more equitable. All of those things that we talk about can be striven for and actually hopefully move towards actually better outcomes in the long term. So this course actually, unlike some of our other offerings at Aquifer, is actually cross-disciplinary. And so it actually has 6 cases that were written intentionally to be across 6 main core clerkships that happen in most medical settings, in most medical schools, and certainly apropos as well to nurse practitioner and physician assistant training as well. These are 6 virtual patient cases that really highlight and then progressively delve deeper into certain aspects of the diagnostic process, why diagnostic errors occur, what happens when those errors occur, what are the harms, and what can we actually strive to do to improve. In addition to those 6 main cases that I'll have a moment to talk about in just a few minutes, we also have 6 mini cases that complement each case. We did that strategically because we didn't want a learner to walk away with the idea that missing diagnosis X is only an internal medicine problem, or that having this certain pitfall in thinking is only an obstetric and gynecologic problem. Instead, these are problems that are pretty universal to human beings in general, but certainly to practitioners across the spectrum of medical education and practice. As I said, this was developed actually with a shared grant from the Doctors Company Foundation many years ago between the Society to Improve Diagnosis, which is the only society focused completely on diagnostic excellence and decreasing harm from diagnostic errors, as well as Aquifer. And it's really been a wonderful collaboration that I'm really grateful to have benefited from. So our 6 cases that we talk about, I'm not going to talk about the many cases, but I'm going to talk about the 6 cases. And as you go through, I want you to, for those of you who may be healthcare practitioners or just people who know people who've suffered from diagnostic errors, I want you to think about how these things aren't rare. These things happen in every hospital every day. And that's why we thought it really important to teach about that. The first is actually a case where we introduce a patient who had iron deficiency anemia and did not have proper colon cancer screening, actually presents with the later diagnosis of colon cancer that's in an advanced stage. There have been some opportunities early on in her care to identify that her iron deficiency probably wasn't from menstrual blood loss or things like that. Instead, it was related probably to one of the things we worry about in older persons who have iron deficiency anemia, colon cancer. So we talk about that, the harms, the suffering that she has due to this, but then also have an opportunity then to present a second patient in this case, a young woman who actually has iron deficiency anemia from menorrhagia. But the same provider is involved and says, this patient needs a colonoscopy because I'm not going to miss colon cancer again. And talking about the importance of calibration, that's probably not a great idea in that case. There's an overreaction, but shows that we know that ordering rates of scans and tests and things is really based on our last experience with them. If the last time I got this test, it was positive, I'm going to get it again. If the last time I got it was negative, I'm not going to do it again. The second case that we'll talk about here is an 84-year-old woman, actually, who comes in with a diagnosis of urosepsis, but isn't getting better, isn't responding to the antibiotics. It's actually really similar to a case I had in the hospital last week when I was rounding, and we said, man, we need to switch the antibiotics. Our diagnosis is, we just need to change the antibiotics. The urosepsis isn't getting better. And then to identify that actually our diagnosis was something else. The patient actually had Clostridium difficile colitis leading to sepsis, thinking that sometimes we need to reevaluate what's going on rather than just changing our treatment. The next case is actually a young woman with pelvic pain, and identifying really delving into why this case may be, identifying that psychosocial factors can have a really significant role. And this patient has a delayed diagnosis, actually, ovarian torsion. And important to identify how that happens. And it wasn't that people didn't know about ovarian torsion. And for the cases I've talked about, it's not like there's a knowledge deficit a lot of the time with things like iron deficiency anemia. That's common. C. diff is common. Ovarian torsion is certainly not uncommon, but to identify that there's ways that we actually identify that we miss these common things. We have a 35-year-old man who actually presents with abdominal pain after an operation, identifying he had an operative complication that was misconstrued. It's actually just post-operative pain, along with a good amount of bias in considering the patient's use of opioids. There's another case where a young patient has chronic abdominal pain, identifying actually that there's some social factors that were missed in this case, leading to a delayed diagnosis, a potentially harmful situation for the child. And then the last one is a diagnosis, a delayed diagnosis of an intestinal malrotation, when the team fails to recognize some of the key signs and thinking that something like intussusception was more common, when in fact there were lots of factors in this case that weren't. None of these things are terribly rare, but we found it really helpful to talk through each of them and identify why did this error occur, talk about it, and then in some of them talk about the harms to the patient and family, and then in others actually talk about the harms to the clinicians and thinking about what effect this has not only on me emotionally, but what about in my future practice? If I've missed something once, am I going to behave differently in the future? And is that helpful or not helpful? Is it helpful to never commit to never missing a number of pulmonary embolism if you get CT pulmonary angiograms on everybody? It's probably a problem. And we have ways that we can seek to continue to strive to improve. Each of these cases, I said, actually is complemented quite nicely by these mini cases that allow comparing and contrasting. And they use some cases with a patient actually with pulmonary embolism who is misconstrued as having asthma, a patient with hyperbilirubinemia that ended up with sepsis and things like that. So some of these cases allow comparing and contrasting between different patients, but teaching the same diagnostic lesson as we go through. So these cases actually are one of the things we do want to highlight actually is that these cases are free for the institutions that already subscribe to other products. We feel like this is such a mission-driven thing. That this is an add-on that you can use to complement your other courses, whether it's aqua family medicine, geriatrics, high-value care, internal medicine, whatever it is. We feel like this is a really nice complement to not only highlight some of these conditions, but really talk about a problem that's of increasing import and actually increasing focus. Remember that diagnostic errors and diagnostic safety are increasingly recognized by the National Academy of Medicine, but also the National Patient Safety Foundation, so many others, on a key and urgent thing that we need to do to improve healthcare in the United States. I firmly believe that the best way to improve that is actually by improving education, and I think this is actually a really important first step. If your institution doesn't subscribe to this, you can actually subscribe for these free courses, which I think is just a testament. I'm grateful for the organization for allowing this, because I think it shows that we're really committed to sharing this information, getting these courses out, so that you and your learners can actually do some real education around improving the diagnostic process. The cases actually are set up like many of the cases that we have at Aquifer that seek to do some of the best pedagogy as well around virtual patient cases, but also model some of the things that are really important around patient questioning, history taking, interactions, physical examination, interpretation of laboratory tests. And this is a case actually of the patient presenting with iron deficiency anemia, who thought originally due to menorrhagia, but actually instead ends up being due to colon cancer. The cases are broken down actually into differential diagnosis, physical exam, the iterative cycle of differential and working diagnosis and final diagnosis, and then talking about how this patient, we witnessed breaking the bad news about that this diagnosis was delayed, and watching the student participating and watching that happen, I think is a really important and often really traumatic thing for all of us. The first time we have to do that, I never saw it modeled before I had to do it as a resident. Not great. And so I really think that introducing these key important things early on through virtual patient cases is a really important thing to do. The cases actually continue as well to really talk about some of the differential diagnosis and allowing students to make that differential, and then talk about why we weight differential diagnosis. Many students leave medical school or your physician's assistant program or your nurse practitioner educational program with the idea that a good differential diagnosis is one that's really broad. And that's actually decent for a beginner, but what we're really seeking to do is identify prioritized differential diagnoses that allow us to work through cases in a way that's efficient and attendant to the patient. As you can see in this case, there's some self-assessment questions that go through and really have the learner engage with the cases and talk about what most likely a year ago was leading to this patient's symptoms. And here we actually identify that colon cancer was actually likely a year ago when this patient presented. This is a good way to introduce this idea, to introduce to the case, to the student in the case, that wow, something was missed a year ago. What do I do? How do I go forward? How do we talk to the patient about this? So as we know that these educator reports are really quite nice to allow that you can see where students have participated in the case, the number of cases they participated in, how far they've gone through, and their case completion. And I think that's a really valuable thing to do. You can see it's really nice for assessments, but also know for many times for whether just tracking student progression or doing that for other means of assessment in your course. I think it's really nice. These dashboards, I think, are a really helpful thing. So the other thing just want to highlight is that these cases are actually sortable by some of the presenting complaints and concerns, and knowing that we have common things here. And it'd be great. There's no better way to teach about colon cancer than a case where there was missed colon cancer, or there's no better way to think about, if we're teaching about this opioid safety. Well, let's look back and think about what are some of the pitfalls in thinking that every patient who presents asking for opioids has opioid use disorder. We have a real opportunity to sort these and identify ways that you can use them in your educational programs as well. One of the other things that we were fortunate that we did early on with this is we realized that this is tough stuff to talk about. And so we were able to make an educator guide that actually has some active learning strategies. Before the pandemic, these were things that you would get people together in a room to do. Turns out you can do them really well on Zoom as well. So to get people to go and do a flipped classroom approach, and that's what we strongly recommend, where students complete the cases in their own time online, and then come together to do these activities that we put together that allow people to do things like structured reflection, diagnostic error fishbones, analyze their own cases. What you'll find is when you start using cases like this and talking about diagnostic errors, the students will tell you what they see. And if you give them a chance to talk about it and share the cases they participated in, you'll be blown away by just how amazingly perceptive our students are and how common these problems are as well. So we really want to talk as well just briefly about some of the ways to integrate these cases into your courses. Where does diagnosis fit? Diagnosis is one of those cross-cutting things that really fits preclinical and clinical education. For compressed programs like PA education, I think it fits pretty much everywhere. I think that these courses are often best either in a preclinical patient safety course, integrated in your specialty using the cases, the internal medicine case in your internal medicine course. We've done some really fun stuff with longitudinal integrated clerkships as well. And so I think that there's all sorts of ways you can integrate this. I think some clinical context is valuable, but you can give enough clinical context to the students as the facilitator to make them really apropos and work pretty well for any level of learner. And we've did research actually early on that looked at using this both preclinically and clinical experiences and found it to be quite valuable. So I'm just going to share one example of the flipped classroom activity as well. So these are activities that you can use and they work on Zoom. There's a detailed discussion guide. You're like, oh my gosh, I don't know how to teach about diagnostic error. I'm just learning about it myself. You can use these and actually do a pretty good job of delivering education to your students. I think it's a really great opportunity. But these are this is an example of a question that would be used in one of these sessions to identify, is this a system or a person level interaction? Does this address cognitive errors? Does this address system errors? What are the strengths of this intervention? What are the weaknesses of this intervention? Because we also want students to walk away empowered to change the system and make things better, rather than just say, oh my gosh, diagnosis error is so common. These in-classroom activities actually really have a nice activity to summarize the cases, analyze cases in depth, and we give more cases, and they're often based on real cases that have been used in the past. And then some opportunities, again, to identify opportunities to make the case better. These cases, these facilitator guides are quite detailed, and again, available on our website and so one of our toolbox for educators. I think are just incredibly valuable, and we're glad to answer any questions about them at any time. So again, I just want to get down a bit specifically about how you might use these. And I think that most of us have preclinical patient safety courses or quality improvement courses. I think rather than just using statistics, telling stories is really valuable. And these cases are really valuable in some of that, and link as well to opportunities that you would be teaching about as well. I actually think as well that sometimes those courses can feel a bit dry, and instead really give the students an opportunity to engage the thing that they love to do, which is clinical care and learning about patients, along with some of those other health system science. That is something that are so important that we increasingly teach. You can use these in traditional or longitudinal integrated clerkships, since they are crossing six major core specialties. I think they work really well. You can use them in traditional clerkships, but we found real success in using them in an LIC. The other thing is some of these courses are being used in transition to residency courses. And I think that's a really valuable thing, is the transition to residency courses are increasingly identifying where those courses are going to land and what they're going to look like. Talking about topics like this, which you identify in your first few months of internship, that this stuff happens, I think is a really, really important and timely thing. We had an experience to do this at the University of Minnesota a few years ago, where we integrated this into our longitudinal integrated clerkship RPAP, which is the Rural Physician Associate Program. There was actually, the students did cases on their own and then came together for a monthly discussion. And what the faculty member who led these discussions told me was, students really liked the cases, and it was an amazing opportunity, however, for them to share their experiences and share the cases they're learning from in the clinic and identify opportunities to improve. And I'll actually pause for a moment and say that if you ask me what's the most important outcome that could come from using course cases like this, is that students feel empowered to talk about and learn from their own cases. If we can produce students who are willing to say, yep, we got that wrong, and we're going to learn from it. If we can identify students to say, this diagnosis process is fallible, I'm fallible, and I can improve, that's an incredibly important thing that we've done. And I think that if we could do that in our schools, in our programs, I think we're going to be a lot better for it. So a couple lessons learned, and then I'll open it up for questions. So first, this is one of those topics, just like high value care, trauma-informed care, many things like that are topical, but not specialty based. These are hard to teach, but yet we can't let nobody owning a topic make us not teach about that topic. We all own diagnosis. And so we can all seek to actually incorporate that into our educational programs. The last thing is, as somebody who does this most of the time, I realize that most people don't teach about diagnostic error all the time and don't have an opportunity to learn and teach about that. And so when we're going to do a topic that's new, you have to give really good integration materials. And that's why we developed all those and made them available as well. So I am going to pause there and bring Eileen back on from Aquifer, who has a chance to facilitate some questions. And I so appreciate everybody joining today.
Excellent. Thanks so much, Andrew. Really appreciate it. I encourage people to go ahead and drop your questions into the Q&A panel, and I'll be happy to bring them forward to Andrew. We've got just a minute or two to cover them. So Andrew, that was fantastic. And we had a question come in earlier about whether you could use the cases across the curriculum or only in a certain clerkship. I think you've addressed that really well. There's a follow-up on that one though. What kind of student feedback have you gotten to the cases?
Yeah, so we actually did some research on that and found that students generally found that they liked the cases, which is probably the least important thing. But they did them, they liked them enough to engage with them. But as students actually, their self-efficacy improved in actually talking about diagnosis error, as well as error avoidance strategies. I think students also, when I've talked to lots of students in using these courses or these cases, felt like they were able to put words to the things that they see in the clerkships and in the wards, so that they're able to talk about these things that are sometimes thrown on, swept under the rug. And so I think that this is an opportunity to give them real self-efficacy and real skills in improving their practice going forward.
Excellent, thank you. I've got another question here. Is there a way to require a certain level of student input on a case? I've seen students skip through quickly or write a minimal amount in the responses.
Yeah, that's the questions here are self-assessment questions that we use, and so certainly you can track completion use, or you can track completion. I think one of the things that I would strongly encourage for something like this is I think this course is best used when you have some ability after the case to have a debrief with the students and engage with it. Because I think that you're going to have, just like with everything, various levels of student engagement in the cases. And so I think if you bring people together and norm it a little bit afterwards, I think that students who might not have engaged in may be like, oh my gosh, I missed out. I need to go back and check on that. And so I think that since we don't have a summative assessment, at the end there's formative questions throughout. We don't have a summative assessment for this. We do have some attitudinal tools that we're working on making available to talk about attitude change, which I think is probably one of the most important things in here. And so it's a great question, but I really think that to me, because this topic is so emotional and so important, finding a way to interact with the students afterwards in a formal, structured way to allow them to make sense and contextualize this knowledge is a really valuable way to gauge some of that.
That's excellent. I know we've got just a minute or no, 2 minutes left. So I want to have you have a chance to go back to your slides and do the wrap up. And I do want to make sure I say out loud to everybody that the slides for this presentation, as well as the recording, will be available right where you registered on aquifer.org, probably within about 24 hours. So if you want to go back and look at the slides or look at the recording, they'll be there for you.
Anyway, thank you everybody for participating. I think that this is a topic that is very much near and dear to my own heart, but I think is really increasingly important. And so I think that we encourage you to use these resources. They're free. We're not making money off these things, and instead to really this is I'm proud this is the right thing to do. And I think we have a real opportunity to learn from this. So these courses are available on our website. But also know that all the educator resources I've talked about here, including the educator guide and those activity worksheets that involve for those flipped classroom activities are all available here in the educator resources at Aquifer as well. So note that there's a bunch of other resources available across Aquifer, including things like high value care. We're excited that we have some partnerships with high value care that we're doing in diagnostic excellence to talk about merging those two really emerging and important things as well. But things like oral presentation skills, and we're excited as well about really important topics that cost cuts as well around social determinants of health coming. So I so appreciate everybody's time. Eileen, I'll let you finish it up.
Oh, that's great. Thank you. The other thing I just want to mention, you can go to aquifer.org. We've got a blog. There's a great article that was written, a blog post on Shark Tank using high value care cases and diagnostic excellence. We've got some user story videos from Andrew up there. We have ongoing webinars. So you can follow us on Twitter or check out the aquifer.org resources. And of course, if you ever have questions, if you're a subscriber, Kate Hancock is available. She talks with U.S. Allopathic medical schools. Leo Romano can help osteopathic schools, physician assistance programs, nursing programs, residential and residencies, international, and they can help non-subscribers as well. If you're interested, please reach out directly to them. You can always learn more at aquifer.org, subscribe. And of course, this course, as Andrew said, is available to non-subscribers as well. So that's it. Thank you so much for joining us, and be sure and follow us on Twitter to stay up with the latest. Really appreciate your being here.
Thanks, everybody.